as they do. And so I'd like to begin by welcoming, on behalf of the Global AIDS Policy Partnership and AVAC, we'd like to welcome you to joining this timely and we believe important webinar on prevention programming during the COVID pandemic. And I think we all understand that prevention programming is different because it requires building trust and relationships and can come in a bottle, but not just in a bottle. And so this poses significant challenges during COVID. And the Global Flood Results report highlighted this challenge with an 11% decline in prevention programming that we saw in the report this week. So today's an opportunity to hear how PEPFAR is dealing with those challenges and what lessons we can keep after hopefully the pandemic recedes, and what areas we need to focus on now that it's with us. And so I posted the agenda in the chat, and we'll start with remarks by Sarah Clucking, who is Senior Technical Advisor and Acting Director of the Office of Research and Science at OGAC, also joined by her colleague Janet Saul, Director of Gender Programming, Erin Eckstein, Senior Global Health Officer, and Jennifer Cole, Program Manager. After that, we'll have a panel discussion moderated by Kiefer Buckingham, who's the Advocacy Director at the Open Society Foundations. And then we'll have the panel would consist of Sarah Clucking and also Marinius Mudongore, the chair of the Key and Vulnerable Population Forum in Tanzania, as well as Kuda Murambetsi, who is a Senior Technical Advisor for VMMC Communications at the USAID-funded Empower Project in Malawi. There'll be a series of questions from Kiefer, and then we'll open it up to questions from the audience. So that's sort of the run of show. And so with that, I might turn it over to Sarah if she would start with her presentation.
Thank you, Kevin. Absolutely. And thank you so much for having us. Let me see if I can get our first challenge here, which is always sharing slides. How did that work? Yeah, okay. Okay. So I will dig in. Thank you again so much for having me and having my colleagues, Erin Eckstein, Janet Saul, and Jennifer Cole. So today we're going to talk with you about innovations and challenges of PEPFAR prevention programming during the COVID-19 pandemic. I'm going to start, let's see if I can get there we go. I'm going to start the presentation today, show you a little bit of data on PEPFAR performance in the last several quarters, focusing mainly on VMMC and oral PrEP. I'll speak generally to some of the COVID-19 support that headquarters is providing to the field and that is available to combat impact of the COVID-19 pandemic on PEPFAR programs. And then also just speak very quickly to a budget question related to the ability to track both prevention and PrEP budgets. Then I'll hand off to my colleagues for presentations on key population programs as well as the DREAMS programs. So I'll start with a quick VMMC update. So PEPFAR has provided over 26.8 million VMMC since 2007. And so in the last 2 quarters, so the update from maybe the last time you saw this slide at the end of FY20, we've seen an increase in 1.8 million. Now, if we break this down quarter by quarter, the data are here. You'll see that 2 things are happening. First, the absolute number of VMMCs experienced a substantial decrease in Q3 FY20, and I've circled that in purple for you here. Now, this does coincide temporally with the onset of the COVID-19 pandemic and mitigation practices. Also on this slide, you'll notice that the annual targets across the years have decreased, and this is due to an age-related eligibility change. So when we take a look at how the VMMC program has recovered coming out of the impact, which is shown in Q3 there of FY20, I'll draw your attention to the red bars, taking a look at achievement quarter to quarter in Q2, which is here. And you can see that the achievement has stabilized. It looks a lot this year as it has in prior quarters, indicating to us that there's been a fair amount of recovery. But as you might suspect, there's a lot of variability across countries. So a lot of the HQ support and field work continues to go into working country by country, program by program, to ensure continued progress in this COVID-19 environment. Now I'll turn now to PrEP. The oral PrEP program really continues to grow, which has been our focus. We started with 4 PrEP programs in FY16, up to 29 or 30 countries now, and scale up is a major focus of the program. If we take a look over the last couple of years at PrEP initiation, so this is PrEP new, you can see that over the course, so in FY19, which had semi-annual reporting, also in FY20, semi-annual reporting, and then FY21, these first 2 quarters where we have quarterly reporting, you do see a steady increase in PrEP initiations. And in the first 6 months of this fiscal year, the OUs, right, as a total at a global level, have already exceeded the total number of initiations in the last fiscal year. So scaling continues and achievement does continue. If you look then at PrEP-CUR, which represents the total number of users, you'll see also here a steady increase with at the end of Q2 of this fiscal year, a little over 614,000 people on PrEP, and that represents about 221,000 more than at the end of the last fiscal year. So it gets more interesting and more detailed when we break this down by OU and country. So clearly, and as you might expect, some OUs are struggling with their PrEP programs, and this is again PrEP initiations, PrEP new. But the progress towards 1 million, the COP20 goal of 1 million people on PrEP does continue in that, and there are 17 at this halfway point, there are 17 out of 26 OUs that have exceeded their last year's total and who are making a lot of progress towards reaching the aggressive goal that is 1 million people on PrEP. That's also demonstrated by PrEP-CUR. So it's in the yellow, these cumulative results where you can see 19 out of 26 OUs have achieved more at this halfway point than their annual total in the last year. And so while certainly one could argue that the targets should be more aggressive, or that if we weren't experiencing a dual pandemic, the COVID-19 pandemic, we could be doing better. Progress is definitely, we're definitely seeing progress. And we continue to be committed, right, to that sort of 1 million goal for this year. And in doing so, we are working hard to expand PrEP eligibility, right, generally in countries, and then also PrEP access and really to all populations with a higher incidence or really who can benefit from this important prevention intervention. So, and to assist field teams in implementation support, I'll refer us first to the PEPFAR technical guidance in the context of COVID-19 pandemic. So I hope you're aware of this document. We do publish guidance across all the programs that is updated weekly. And this is, again, a public forum. You could go to this website here. And this provides a number of best practices and adaptation suggestions for our field teams. We're also collecting this information and have been from the very beginning of this journey in order to disseminate best practices and ideas for adaptation and workarounds so that we can ensure that PEPFAR services, particularly in my interest, the prevention services, continue to be provided in the COVID context. We're also putting that out on a public-facing platform now with the reinvigoration of the PEPFAR Solutions platform. So watch that space for this fall for some of these solutions to come forward. And then I'll mention 2 more things, the supplemental funding. We were very pleased to receive some supplemental funding through the America Rescue Plan Act in order to address adaptation and program injury. And there's also, headquarters has been developing integrated analytics platforms to support our teams to do the data analyses they need to really side by side take a look at the MER reporting and the performance of their PEPFAR programs alongside the key temporal components of their COVID pandemic in their OU in their country. So it's a real integrated platform that really helps them understand where those key intersections are for program impact and hopefully allow them to focus in on where adaptations and changes need to take place. Okay, so there are many adaptations and innovations to PrEP programs and prevention programs generally, which have enabled the programs to continue and persist. So my colleagues will go through these programs for you. But before I hand over the mic, I just want to take one minute to focus a little bit on budget. So just to say one quick word, there seem to be some concerns around the budget transparency around prevention and PrEP budgets. And so I just want to let folks know that both prevention and PrEP budgets are available through Spotlight. So publicly available website. They are not easy to find. It's rather convoluted. The instructions are here, and I will be sure to share this deck for all who are interested. But if you go to this site, you'll be able to see that at least on the PrEP side and on the PrEP side, prevention side, but COP18 PrEP budgets were, the expenditures there were 17 million. COP19, that was up to 35 million in expenditures. COP20 PrEP expenditures are not available, but the planned budgets are available, and that's at 101 million. So that's been the trajectory of PrEP funding, at least in recent years. And I encourage you to then go to that site because COP21 planned budgets, right? So for our following year will be available at the end of the month. So you can take a look at the trends there. Okay, so I will now hand off to Erin Eckstein. Thanks so much. Erin, would you like me to try to pull up your slides or what? Maybe
Sorry, if you can, Sarah, that would be fantastic, but otherwise I can also do it.
Maybe not.
No, I think they're there. Just
maybe I'll stop share and then start share.
That sounds good. It still says I'm viewing your screen, which has my slides.
Those are the dream slides. Let's see if I can find the KP slides. Apologies. Oh, here. Okay, let's try this. Presentation mode. Are we good?
Yeah, that's awesome. Thanks so much, Sarah. Really appreciate that.
Not a problem.
So hi, everyone. I think many of you know me, but I'm Erin Eckstein, and obviously with the Office of the Global AIDS Coordinator, I serve on our program quality team along with Sarah as the director of our Key Populations, Human Rights, and Community Engagement sub-team. I'm also joined by my colleague, Jennifer Cole, who's also with us, who serves as a KP advisor. So thanks everyone for having us. And Sarah, if you wouldn't mind going to the next slide. Thank you. So go back one more. I know we're here today to talk about the key populations programming in the prevention space. I did want to just take as my hat as also being one of the primary points of contact for civil society organizations writ large in PEPFAR. Many of you may have seen an email this morning from Anjali Achrekar, our acting global AIDS coordinator, just updating us that there is a next iteration, a next draft of the PEPFAR strategy up on our website. So I just wanted to make sure you all have that, as I know the GAP has been, an extremely valuable participant in sharing ideas and providing commentary. So just wanted to start with that to let you know, as of this morning, there's new information up online. So please take a look. And Sarah, if you wouldn't mind going to the next slide. So I just want to ground us in a few minutes. Many of you who joined our town hall back in August have seen some of these slides before. I did want to just provide an overall snapshot of the KP program and target performance at the global aggregate level as of Q2. Now, this cuts across the cascade. Obviously, today here we're talking about prevention. I'll also note we did have to, thanks to our colleagues at AMFAR, we did actually make a mistake on the original version of these slides. So just letting you know, these are actually updated and corrected. We had some, we made a mistake with the KP Prev presentation across some of the key populations groups. So just want to start by sharing some global observations across the different key populations groups. This is as of Q2. COP20, fiscal year 21. So just in terms of the prevention space, in terms of our KP-PREV target achievements, if we define being on track as achieving 50% of the target as of Q2, we can see our female sex worker programming is hitting that benchmark. Again, this is at the aggregate global level. And just hitting that benchmark in the case of PrEP. If we go to the next slide, for gay men and other men who have sex with men, it's a roughly similar story, more than on track for KP-PREV. PrEP-NEW just under the benchmark at 49%. If we could go to the next slide, please. Now, prisoners, our prisoner programming across the board is a place where we really need to see improvement. But just noting the numbers here: 41% for the KP-PREV, the primary prevention indicator, and then 48% for PrEP-NEW. If we could go to the next slide, please. For people who inject drugs, we're at 67% on KP-PREV, 74% for PrEP-NEW. If we could go to the next slide. And then for transgender people, similar story at 72% for KP-PREV, 44%, a bit under the benchmark for PrEP-NEW. And then if we could go to the next slide, this just sort of synthesizes all of those things I just showed you across all of the groups. Now, as I noted, and similarly to what Sarah pointed out, this is of course global aggregate achievement. I will note that in many cases, high numbers and high achievement in a few OUs, particularly Nigeria actually, are driving some of these numbers. So then when you break it down, there isn't necessarily this, you can see across the board here, we're close to 50%, if not over, and then a little under in some cases. Of course, once you dive down to the OU level, it's a different story with some OUs kind of making up ground where others are struggling. Next slide, please. So I, again, just want to remind folks, as Sarah did, we do have our COVID-19 guidance up, and in terms of KPs, we continue to prioritize uninterrupted HIV treatment access, really emphasizing decentralized services, particularly for prevention, but also viral load testing, and emphasizing community platforms. And then, of course, really just continued coordination and collaboration for the case management teams, not even just within the PEPFAR program, but finding ways to access services and resources for key populations that cut across funders and program areas. And then, of course, really pleased just last week or the week before, there was the Sequin differentiated treatment meeting that really highlighted a lot of examples. Of course, the focus wasn't necessarily on COVID, but just as we PEPFAR think about, how we're operating now, and we're actually gearing up for COP22 guidance writing, and just really emphasizing those differentiated service models that we really need to prioritize and continue to scale up. And of course, particularly in the testing, prevention, and PrEP services space, of course, DSD models are important there, but wanted to just emphasize here today, leveraging those virtual approaches. I think we've seen a number of our OUs. We're already starting to do that pre-COVID, but of course have accelerated with COVID and responding to the different lockdowns and various challenges that they have encountered, and that includes use of social media, phone, SMS, et cetera. If we could go to the next slide, just want to note being very grateful to the Gates funded work, and through, I'm sure, many of you here have been involved with the HIV Prevention Coalition, and getting that Going Online guide up, which really draws from a lot of the USAID EPIC KP program experiences over the past year and a half. And then, as Sarah noted, we are reinvigorating the PEPFAR Solutions platform. in fact, Jennifer and I just came off reviewing some, in the KP space. So really looking for those opportunities to document what's working well, get it up on our site, and hopefully, encourage and promote replication across the program. Just wanted to take a minute too to reflect. Sarah mentioned some of these increasingly sophisticated analytics that our Prime team has been putting together, which will be really helpful. I'm a little reluctant to put up some of our trends, just because there's so much variability in targets, the way targets are set across different KP groups, different OUs. And just even I serve, in addition to sort of my quote unquote day job, I'm also the chair of our Asia region program. And just thinking through some of the, our team in India has had some really sophisticated analytics just in looking at, the different, waves and waves of lockdowns, and how that's really affected our programming. So I think, just as Sarah noted, looking to really be able to integrate our own trends and MER analysis, but then also the broader COVID backdrop, both in terms of incidents and the background policy environment, and how our partner country governments are responding with various mitigation measures. But we're really looking forward to being able to dig into some of those analytics. And that, at this point, is my last slide. And I will turn it over to Janet, and do really look forward to the discussion and questions. Thank you so much.
Okay, I think I'm off mute. Sarah, is it possible for you to share my slides as well? Thank you, really appreciate that. And good afternoon, everyone. I am thrilled to be here to talk about this, because this is something obviously that's been on all of our minds. Sarah, can you possibly put it in slideshow mode? If not, it's fine. It'll just be a little bit bigger if it's in slideshow. So I want to talk a little bit about the innovations and challenges that we've had in providing dreams during COVID-19 pandemic. Hang on, we're gonna go back to the slides, I think. Yay, thank you. So next slide, please. Next slide, yes, thank you. So I want to show you a little bit of, great. I want to show you a little bit of data first, and then talk about, what are some of the adaptations that we've made. So looking similar to how, Sarah and Aaron presented data, looking at, from Q2 last year to Q2 this year to see, what does that look like? And what this slide is showing, basically, when you look from last year, Q2 to this year, is that we're reaching actually even more AGYW in dreams. It means we're enrolling and engaging even more than we did last year at Q2. But fewer of them have completed what we call the primary package, or the set of interventions that they should be completing for their age group. And this, we think, is probably due to a couple of factors, COVID-19 being one of them, and I'll talk a little bit about which interventions are harder to implement during the pandemic. But we think that definitely has impacted the ability to have the adolescent girls and young women complete the package. But there is a confounding issue, which is that we significantly changed our economic strengthening component of dreams this year to something more intensive. We think it will be better. It's more evidence-based, but for the older, say 18 to 24-year-olds, for them, it will take them longer to complete the core package than it has in the past. So that's probably contributing to this as well, but definitely COVID is a factor. Next slide. So in the spring of this year, we reached out to our country teams and we asked them, what what's happening? Where are you at right now with being able to get AGYW to clinical services and get them to community-based services? And what we found was that really the clinical services were less impacted. They seemed to be more stable and able to get young women there when they needed to get them there. The community-based services, much more impacted. And what we heard from them, and that was this spring, right? What we heard from them this spring is that 100% of them said, we have had to adapt in some way. They've gone through different times when programming is paused and then it starts back up again. They've had to adapt as far as decreasing the size of groups. And so there's a lot of adaptation going on. It is happening, but it sounds like it's happening more slowly and kind of with, you know, fits and starts. Next slide. So this is looking at, you know, if you look at different different services, like what is the impact on them? And so we looked at PEPFAR, which we look at for DREAMS in DREAMS geographic area, specifically for AGYW. And what we see there is that in Q4 of last year, you see a dip, but then you see a recovery. It will definitely be interesting to see what happens in Q4 of this year, because I think, you know, we're going to see how prevention fared during some of the surges that happened, the COVID surges that happened in a lot of the countries in which we're working. Then when you look at PrEP, this sort of speaks again to that community-based small group in the community kind of services versus clinical services. What you see with PrEP is that PrEP actually is doing better than something like PEPFAR, where you're relying on meeting in small groups. So next slide. And this speaks to the issue of, you know, that we've all been talking about globally, about the potential for increased violence, particularly GBV or intimate partner violence. And this isn't a measure of, you know, how much violence is actually happening. We don't have a measure of that in our program indicators. But what we do have a measure is how much post-violence care we are providing. And you will see that we did have an increase from Q4 of last year to Q4 of this year in the number of AGYW that receive post-GBV services. And we'll be able to look at that. That's an annual indicator, so we'll be able to look at that again at Q4. But it's an indicator that more young women came in and asked for these services. Next slide. So what are we doing about all of this? How are we dealing with these issues of trying to deliver dreams during this pandemic? Next slide. It's been a very phased approach. So, you know, in spring of 2020, we didn't really know what we were up against. So we made it a priority for our teams and our partners and our mentors to stay in contact with AGYW. We didn't want to lose them, right? We wanted to stay in contact and obviously get them to any clinical services that they needed. At that time, we also gathered information on how many of them had access to phones so that we could see, like, can we start to deliver some of these small group interventions? Could we figure out a way to do it virtually? And what we found that only about half of them had access to phones. And when I say access, I mean either they had their own phone or they could use a sibling's phone or a parent's phone. So that's how we started out. And then we started talking about, okay, this is going to go on for a while. How can we figure out how a continuum of engagement, but not really delivering full curricula? And I can talk about that a little bit, right? Part of it was efficacy issues. We had no idea if what we usually deliver in a small group intervention would still work if we did it virtually. And equity issues around, you know, the fact that only half of the AGYW would have access to the programming if we went fully virtually. So then we moved into the spring of this year, and we started to talk more about, okay, well, maybe we can't deliver the whole program virtually, but what can we deliver virtually? And that's where we've started to move this year in spring and summer of 2021. And I can talk a little bit more about that if you'd like. But we are doing some, I will, on another slide, I'll give you more detail on that. So next slide. And so this is our continuum of how we're delivering things. So we have some very basic ways that when there are lockdowns happening, and what we've learned is that a lockdown happens, then it opens up. Then a lockdown happens, then it opens up. So during the lockdowns, what we've asked is for them to check in with the AGYW, maintain contact, see how they're doing, see if they need any clinical services or other support, continue to provide some basic information, reinforce messages that they're learning about and hearing in dreams. And then, all the way to curriculum delivery, which I already said, at this time, we're not delivering full curricula virtually, but we are looking at how we can do some of that, do some hybrid, so that, when they can meet in person, they do, and when they can't, how can we do some of this virtually? Next slide.
Janet,
so this is where we're at with that.
Sorry, I think we might just wind down a little bit with this. This is all really, really great information, but we want to have some time for the discussion. But thank you so much.
Absolutely. Okay, so we can skip over here. This just gives some more details of what we're doing virtually. And then just one thing on how we're responding to GBV. We really made sure in the countries that we advocated with host governments to make sure that GBV and child protection services were delineated as essential. That wasn't true, so we had to do some advocating. And then we have our teams and implementing partners continuously updating to make sure that we know what's open, what's operable, et cetera. And staying, as I said, in close contact and making sure that we can get people to services when they need them. And I think we can end there. We're good. Thank you.
Thank you so much. And we'll just turn it over now to Kiefer. Thank you much for all those great presentations.
Yes, thank you so much. It's great to hear from our team at PEPFAR. I just really appreciate all the work that y'all are doing. I know not only on the ground, but also in offices in Washington, D.C. and other places, trying to help folks adapt, especially in this really challenging COVID-19 environment. So as we go into our panel discussion, first want to hear some brief remarks from both Kuda and Marinus, who are going to be joining us for this section. Kevin already introduced them. So we're going to hear from them, and then we'll have a brief I have some initial questions, but I know that you on the call, I know we were joined by many experts in their own rights on this call, so we want to open it up to you. So maybe first I'll hand it over to Kuda to provide some initial thoughts, and then to Marinus, and then we will have a discussion with our broader panel. Kuda, over to you.
Excellent. Thanks so much, Kiefer. I think the first thing I want to just be thankful to be able to join in this important discussion. I think the COVID-19 pandemic really did bring, with it a number of challenges for prevention programs. And I think in the HIV response, it's essential that we find this time to highlight some of the challenges that we came across. But there are also some key innovations that we managed to use or to jump on to circumvent the impact of COVID-19. And some of those key innovations will, live longer or last longer than the pandemic itself, because some of those innovations, we've come across some efficiencies that those innovations would provide us. So I really liked the initial presentation. I think I'm coming from a voluntary medical male circumcision program in Malawi. Our program is called Empower, and it's got 3 components: one on VMMC, one on some work around the DREAMS database, and the other on comprehensive condom programming. But I'll speak briefly on the impact of COVID-19 on the VMMC program that we've seen in Malawi. And I think the things that have been highlighted key to us, I think in the previous presentation, there was that dip that was shown in the early phases. I think that was in Q3 of last year. You'd realize that for Malawi in early April 2020, the ministry did provide a determination that the VMMC services are non-essential, and that would have meant that we had to temporarily, deploy our staff to ART clinics, which were essential for continuity of care and treatment programs. So we did meet quite a number of challenges, some which we'll discuss today, but just in brief, I think from a service delivery perspective, we had challenges around, infection prevention and management of exposures for, our clients and our staff. And that really also disrupted services. And coupled with this idea of continuous service disruptions, we did have challenges with coming back and building that trust with communities, with service restarts and so forth. But the major challenge, I think, with COVID-19 has been on the demand creation front as well, where we've had that limited crowd gathering, which means we needed to rely on maybe IPC with no reinforcing mediums. And interpersonal communications requires that you have these reinforcing mediums. So I think as we go along, we'll speak a lot about some of the challenges that we've met, but just in brief, I think from a service delivery perspective, we had issues to do with closures, when the clinics had to manage exposure and infection prevention. When a clinician or a service provider was to test positive, we had to close up our facilities. And once we've closed our facilities, it means we need to disinfect those facilities, and that was a lost opportunity. So we had some serious challenges in the first phases. And with regards to demand creation, again, we had some adverse impacts that we saw around the issue of even the vehicles that had to carry the staff or the clients. Those vehicles, the carrying capacity had to be reduced due to COVID-19, means we had to trickle clients into the service delivery sites. So I think as we go on, we could highlight some more of those challenges that we met and some of the innovations that we've put across just to run away from the impact of the pandemic. Thank you.
Thanks so much, Kuda. I actually think that's a really interesting and important point around, it's not just about a clinic closing or a lockdown or prevention of large gatherings, which we're all familiar with, but even the little pieces of y'all working to try to get people from maybe to their homes or their neighborhoods to a clinic, and about how many people can be in a car at once, right? So that's really, really interesting and helpful, I think, as we continue to think about the specific challenges that we're facing in implementing these programs. Marinus, I want to turn to you and your example from Tanzania and talk a little bit about the challenges that you've seen and the adaptations from the community side. You're muted, Marinus. And I also just want to say, I know what time it is there, so appreciate you joining us.
Yeah, sure. Thank you very much. My name is Marinus Mutongole from the Tanzanian Vulnerable Population Forum, the KPP Forum. This is a forum led by key and vulnerable population and consists of all vulnerable groups. So for us, Tanzania, on the innovations on tackling problems of HIV in line with the COVID-19, we have been struggling actually, particularly on PrEP as a prevention. As up to now, Tanzania has not yet scaled up PrEP, so we had completed the pilot like 2 years ago, and it has good information that resulted to the scale up. But up to now, we are still struggling. And many reasons had been behind that, including the myths and misconception from the other multi-stakeholders, and also the COVID-19 in one way or another caused some delays because of the outbreak. So we even thank PEPFAR for issuing different guidance on how we can continue with the services despite of the COVID, and also the American Rescue Plan. We are very grateful for chipping in, but we would like also to, because the communities, we at the forum, we are doing some supportive supervision and technical assistance to different facilities and at the community level where the demand for PrEP is very high. Actually, people need PrEP, but everything need to be in line with the government protocols and etc. And of course, we were involved within the revision of the framework, and now it's promising that the training has started, and it's said that it will be scaled up. But this is my call also to PEPFAR again, to call upon to continue assisting the countries which have not taken measures to accept these critical prevention programming as like it's seen in another country, that it highly work and it is very efficient. So for our countries, like when we were lagging behind, it's very important that to put some stringent condition within this grant so that it's well implemented. On another thing, I would like to talk about how PEPFAR has supported these innovation techniques on supporting a country like the DSD programming. Though it is not well effective, but we need also continuous support to get educating or imposing some technical assistance to our country, like the application of the different service delivery, like when the services needs to come to the communities. It's like this many services are still centered at the facilities, but the communities, most they don't go to the facilities. So it is my pleasure to get to this platform, and I would like to emphasize on the stress that we are the strain that we are getting, we as communities, and I would like to call upon to put much emphasis in having our country also to be in a good platform like other countries that have been succeed in implementation of the programs. Also using KP-led organizations. For instance, we had the KPF, Key and Vulnerable Population Investment Fund, that is now ending in September. This program has helped a lot in identification, demand creation of and identification of positive and linking people to treatment, and also creating some emphasis on putting people on retention. But as the program is now ending, we have a lot of gains that were obtained. But as the program is ending now, we don't have any kind of know how we can sustain these programs. So like call upon, if there's a possibility to support a country like Tanzania to have another kind of maybe of grant that will also or engage this organization, KP-led organizations, into the COP funding so that they make well their progress. Thank you very much.
Thank you so much, Marinus. I really appreciate your intervention, and again for both of our colleagues for joining us at this late time in the evening. I actually want to start there. I'm going to go ahead and take moderator's privilege. Although this issue has been mentioned in the chat, I've been monitoring the chat, is the Key Populations Investment Fund. So KPIF is winding down, and many programs have already ended across the board from this near $100 million that was distributed a couple of years ago after a couple fits and starts. So Richard Muko in the chat talked about KPIF and it being a great program that really did maybe not as much as we had hoped, but did involve KP-led or KP, what we call KP competent programs and implementation. Marinus, you talked about how that created a lot of demand for prevention programs, including PrEP, which of course is a tough position to be in Tanzania, where, as you said, scale up has not really happened. But the big issue here with KPIF is scale up and sustainability. We saw tremendous outcomes, especially among trans folks that were specifically being served by this program. And Aaron, in your presentation, you also mentioned, and we saw in the data, how your different KP groups, transgender people are really falling behind and these programs serving trans folks are falling behind in the various metrics and goals that we have set. So I want to really kick it to the panel. How do we scale up what we know actually works? I think a lot of times there's excuses for prevention, that it's hard to measure, that it's hard to evaluate because we're evaluating negative, we're not evaluating positive cases, we're evaluating people not getting HIV, right? And so I want to talk about and hear from folks ideas on how to scale up and sustain programs that we know work, like the ones that we saw from KPIF. So I'd love to hear from any of our panelists from the government, or also from Marinus and Kuda, about ways that we can work together to do that. I'll open it up to you. Thanks.
Hello.
Yes, please start, Marinus, please.
Yes, Clark. So for my idea, what I was thinking, we had the KPIF, which has passed, and this program also did very successful on reaching people, creating demand, testing, linkage, and when it's phasing out, in order to sustain the gains of the program, we need to get this KP-led organization, which did well, to be absorbed into COP, the country operation planning, where they will continue collaborating with the KP competent organizations that were there before. So these KP-led organizations that were chipped in with the programs did very well, and the results are seen. Personally, in Tanzania, we had 10 organizations, the KP-led organization, which did very successful. And because the program needs to be sustained, they have the staff that they employed, they have the offices that they lent using the KPIF. So these all efforts should not be only threatened by the ending of KPIF, should be sustained within the COP funding, because the COP funding there. So it's just some good recommendation for this organization, basing on their performance, to be absorbed so that they do things continue to do things in a better way. Thank you very much.
Thanks, Marinus. I know some of this is our government colleagues will give you an out because you can't, I think, legally ask for more money. But with the, I'm wondering what specific things PEPFAR is thinking about in trying to sustain some of these lessons learned and great results we saw out of KPIF.
Yeah, thanks all. I know, we've been talking about this for a while, and I will say, just even in the past few weeks, a number of us have been charged with some, I guess I would describe it as sort of deep thinking about what is, I don't want to use the word game changer, but essentially what is that, right? And I can't say right now exactly where that's going to go, but I think exactly the questions that you're asking right now, because sort of the way I personally have been thinking about it is that, through KPIF, we've demonstrated a number of things that work. And now what we're talking about is a problem of scale. And so that problem of scale has a number of components, right? Some clearly the enabling environment that key populations face, whether, outright criminalization or just broader stigma, discrimination, et cetera, violence. So there's that enabling environment, and how can PEPFAR influence that? Then there's a question of actual resources, and what do we need to do, both working with partner governments, but also even within PEPFAR, to sort of structure that conversation and to kind of lay down a framework for that. And then I sort of think about it as the broader enabling environment, but then also PEPFAR's enabling environment, and kind of working through some of those things. So, I think kind of exactly what a number of the questions and considerations you all have laid out. I mean, this is exactly the kind of thinking that we're doing right now, and have been sort of charged to think about, both in terms of the longer term strategy, but also as we approach COP22.
Thanks, Erin. And if I can just put in a plug, I think as y'all are doing that internal thinking, there's a lot of folks on this call and not on this call who would love to help you do that, right? I mean, I think as a community, putting our heads together and thinking about what are those big bets that need to be funded, but listening to the communities, especially the folks like Marinus and others who are on the ground, who have implemented these programs and can tell the stories about what has worked and how do we scale up. Another question that has really been brought in is PrEP. So we thank you for the presentation on PrEP and PrEP data. A couple questions, from Matthew. He asked about, sort of tracking PrEP continuation. So I think one question would be, as we, for example, track people dropping off from being in HIV care and what that drop off looks like after initially getting into care and getting on critical life-saving medicines, what does that look like for PrEP? Are we tracking just people initiating PrEP, or are we also tracking folks who, are dropping off and for reasons that they may be doing that, similar to what we do with folks in care? So just a question from Matthew on that.
So thanks very much for the question. There is a lot of discussion on how to characterize, how to monitor retention, right? I mean, it's not we need a different word for it, or continuity of PrEP use. But, there's a good understanding that PrEP and taking PrEP really correlates to your risk environment, right? And your understanding of sort of when you are at risk of contracting HIV and when you're not. So there's a lot of interest in the community to understand continuity and use around PrEP. And there is some discussion of a new PrEP indicator, right? And we may be seeing this fall. Again, it's still under discussion for the next fiscal year, but something that would speak to the number of individuals, right, that return for a follow-up visit, so their 3-month testing visit or the like, or a reinitiation visit. So in that sense, we'd have PrEP news, right, sort of new folks being initiated, and then PrEP continue, right, which is this reinitiation or follow-up. And I do think that could, as a required reporting element, I know there are a lot of IPs out there that are keeping track, right, of repeat visits and continuity through their programs. But as a required reporting element, I think that would give us some really valuable additional information that we could use to understand the dynamics of PrEP use in different populations and different environments, as well as stock issues, right, supply chain issues, and basically the need around some of these products. I think you'll also see potentially a broadening of PrEP to new products, right? So we've obviously, for obvious reasons, focused on oral PrEP as the biomedical prevention intervention, but we're seeing some new products come on the market, such as the dapivirine vaginal ring, potentially long-acting cabotegravir, and we're proactively, right, trying to position ourselves to be able to move those products into use when the time comes. Over.
Great, thanks so much. Another question that we only have a couple minutes left, but another question that I've had is about evaluation. Because, and I mentioned this earlier around prevention, sometimes it's hard to tell the story in the negative, right? I mean, it's because you know, we're not really counting people served in a clinic as the same, or how many people start ARVs, right? So I think you talked a little bit about the budget question and tracking the budget, and we appreciate that, especially the instructions, because we'll all go and dig in, and probably not me, but other people smarter than me will go and dig into the budgetary implications. But in terms of budget, how are we thinking about specific budget for evaluation? So not just tracking, but actually evaluating programs. So, you know, I think to your point, Erin, around big ideas, sometimes we fail, and that's fine, but we have to try them. But the only way we can do that is if we have robust evaluation and we have support and funding for evaluation, so that we can go back and tell the story, whether it's to PEPFAR about COPS or it's even to Congress about funding, right? So would love to know a little bit more about, whether it's through the COPS or through other processes, how do we fund for evaluation and ensure that there's enough funding there to be able to tell the story when a program works or doesn't?
Thanks, Kiefer. Say, Janet, not to call you out, but are you in a position to talk about some of the evaluations on DREAMS, looking at reduction of incidence in DREAMS districts relative to other areas? Over.
We can't hear you, Janet.
Oh, yeah, Janet, you're on mute.
Because I'm doing it through my phone, sorry. No, I think it's an important and complicated question that you ask. I mean, I think there are really good ways to evaluate prevention. Where we run into issues is that our prevention is so comprehensive and complicated that's the issue. And so, yeah, we've tried with DREAMS to use a variety of approaches, right? We have implementation science and impact evaluation that Gates funded, but that was in very limited places. So to look at DREAMS programming overall, we've done modeling, which, you know, there's been some criticizing of us using the modeling that we've used, but we want to look at the whole program, like across 15 countries, and those programs are all very different. So it's a funding issue, but it's also a like really big brain, like how do you evaluate the kind of programs that PEPFAR does, kind of an issue as well. And yeah, I mean, I think the more evaluation we can do, I think I agree with you, and I think we try to always look at our program data, right? But you know, having some additional data would be great as well. So I don't know. I haven't really answered your question. I don't know the answer, but I think we have to figure out how to try some different approaches and then triangulate those different sources.
I would just add, I mean, I think that I also don't have the answer, and I don't have the right kind of brain to provide the answer, but I will say that you know, I do think as part of that, like those big ideas thinking, I mean, I know that is, you know, that's what we grapple with. I mean, it's across the board in prevention, but particularly in the KP space, going beyond prevention. I mean, what are our numbers really? I mean, you know, just even as a chair for a number of Asian countries, which is, those are primary, I mean, our entire program is a KP program. And sometimes even just knowing, you know, getting those numbers right. Where are we? What are we doing? How far have we gotten? And then, you know, there was a fascinating supplement, which I'm sure I think many in this group were part of putting together right before IES, just, you know, on the future of the epidemic in sub-Saharan Africa, and what are innovative ways of kind of being able to, in a way, make that investment case for what, you know, ongoing transmission among KPs. How does that, you know, how does that stop us from reaching our goals and being able to quantify and look at that? And being able to make that kind of case. And, so just those, I'm not the person to do the analysis, obviously, but, really thinking through like, what are those numbers, or just also being fascinated by, still haven't completely wrapped my head around it, but, a number of where we are with the prevention targets that UNAIDS put out in the most recent report, and where those gaps are by population and by intervention. And I mean, I think my takeaway is we have to think differently. And so where's, the money, the leadership, the brains to do all that is I think the question that we need to get to.
Great.
Kiefer, are we at time? I think we're at time.
Yes, we are at time. We're a little bit over time, but appreciate
it. Yeah, it was an incredible discussion.
Yeah.
Maybe I could just end up by just really thanking our OGAC, all of you, Sarah, Janet, and Aaron for really amazing presentations, and for really being willing to engage, and looking forward to the big thinking, what comes out of that. And also to thank the Kiefer for amazing questions, and also for Marinis and Kuda for joining us and providing their perspective. So anyway, thank you all. And I understand that, Sarah, we might be able to get some of those slides later after you've cleaned them up, so we'll be sharing them around. So thank you all for joining. And if Kiefer, do you have anything else to add?
No, just thanks so much, and looking forward to continuing the discussion with all of you.
Yeah.
Thank you.
Bye-bye.
Thank you.